You've been stabbed in the back and the rest of your body. Won't you tell me where you're bleeding from? If you need a tourniquet or if you want to turn and quit, know that I'll be by your side. You bled your whole soul into things you can't control in a world you'll never satisfy.
Welcome back to Stretcher Fetchers podcast. Speaking of bleeding control, my schedule has absolutely hemorrhaged in the last 2 weeks. I attended the instructor coordinator conference and I had a recent family event that took some time dedication, but we are back. So, welcome to Stretcher Fetchers podcast. This week, we're going to be going over bleeding control and touching on some typical blood thinners that you're going to run into on the field. Just the typical spiel. None of my opinions or my statements are affiliated with my department. Without further ado, let's get flowing. The normal human body contains about 10 pints of blood, and this does vary for size and age of the person, but a normal adult has about 8 to 10 pints of blood. So, when you guys have a patient with an injury, and this can be anything from a broken bone to a massive hemorrhage, any type of blood loss is going to impact the patient's mental status and ability to compensate for the current situation that's going on. Going into 2024, my Kent County protocols actually released a new protocol called Bleeding Control or BCON. And this is kind of a guide for any patient that has a traumatic bleed, such as a penetrating wound, a laceration, or any type of trauma that happened that would cause massive blood loss. But this also covers non traumatic bleeds, like a patient that has a hemorrhage coming from a hemodialysis port or any type of maybe surgical complication outside of the hospital setting. So, when you guys come up on scene and you know that you have a hemorrhaging patient or a patient with a massive bleed, these do include scalps because those suckers bleed like no other. Try and make sure that you guys have something with sleeves or protect yourself from any bloodborne pathogen exposure. To start with, you're going to apply direct pressure to the site that's bleeding, and this could be done with your typical 5x9 abdominal pad or even a 4x4, whatever you have available at that time. You're going to apply direct pressure for 3 to 5 minutes, and this is putting a large amount of your body weight behind this. Make sure that you are not lifting. One of the things that I just recently heard that I thought was pretty amusing was don't peek because it'll leak. And it makes sense. Also, try and use some type of non adherent bandage if you guys do have that available. The reason that we would want to try and use some type of non adherent bandage for bleeding control is it has this like plastic wrapping that doesn't allow for the scab to form into the gauze. If there's a long transport, then it can be quite problematic to try and remove in a hospital setting. But seeing as we're EMS, we're not necessarily concerned with the removal of the bandage as much as we are actually controlling the bleeding at hand. Now, once that 3 to 5 minutes is up, or you see that bleeding is coming through your pressure bandage that you've put onto the patient's site, then it's best practice to apply a second abdominal pad or a second thicker bandage that you can use to try and control that bleed. And if it stops at that point, wrap it up with gauze and call it good. Check on it periodically. But at this point, if it doesn't stop and it's an extremity wound, then you're going to want to apply a tourniquet. Now, typically in our EMT class, when we're going through school, they always taught to apply a tourniquet high and tight. But with these revised protocols, they now advise that you do not put them at a joint. Instead, you try and put them around 2 to 5 inches above the laceration site. This is going to be tightened. Everybody has different tourniquets that they're going to be using, but you're basically going to tighten it until the distal pulse disappears. At this point, if you've done it correctly, the bleeding should stop. Now, if the bleeding does not stop and you have a larger individual or you have a difficult extremity to try and get the tourniquet applied to, then our protocol does give us permission to apply a second tourniquet, more proximal to the core of the body. When you're getting ready to place the tourniquet, make sure that you're educating the patient. I will always tell my students that I'm teaching that an educated patient is a compliant patient. So, obviously, if there's this massive bleed, the patient's going to be freaking out. Just simply saying what you guys are doing to this patient is going to help calm them down and kind of prepare them for what's ahead. This tourniquet is going to be extremely painful, so throughout this process, we're going to be trying to see if they can wiggle their fingers or toes and see if that motor sensory is still intact. Obviously, the pulse is going to be gone, but you should periodically check that pulse site to make sure that it is still not present after a tourniquet has been placed. When we talk about type of things that could kind of decrease sensation or motor ability, one of the big things with the upper extremity is that ulnar nerve. The ulnar nerve runs from your pinky all the way up to in your armpit, and it runs right underneath the brachial artery. So when you put prolonged pressure on that ulnar nerve, it can cause the rest of the hand to go to sleep, but it can also leave impacting injuries. We are always going to favor saving life over limb, but we should be sensitive to the fact that the patient is still going to have lasting pain after the tourniquet application. Maybe think about adding some ice to help with the swelling and the angered area, and just monitoring the patient, giving words of comfort and support throughout the process, and periodically monitoring goes a long ways. Now, for podcast sake, so that I don't have the shortest podcast about bleeding control or bleeding in general in the world, you have a wound that would actually benefit from packing. This is where I would instruct my students to not favor using 4x4s and packing multiple 4x4s in the wound, as you can potentially lose any type of loose gauze that is packed into the wound. You have a way better accountability system when you're taking a rolled gauze and putting pressure inside the wound to the point that the skin is almost having a little bit of bulge to it, and you'll be monitoring the bleeding control from there. Depending on your department protocols, it would be a really good thing to take a picture of the wound before you dress it. So that way, ALS doesn't have to take down the dressing or kind of visualize it, risking the chance that it's going to start bleeding again. If worst case scenario and you don't have time to take a picture, take a good image in your head and try and figure out the depth and the width to describe to EMS, even if you have to show by using your fingers with how deep or how wide it is. Anytime that we can keep that dressing on until we get into a hospital setting is going to be a huge win for the patient. When a patient has lost a large amount of blood, they have this process that the body goes into called hemorrhagic shock. And hemorrhagic shock occurs when a substantial blood loss reduces perfusion, resulting in insufficient oxygen delivery to the tissues of the body. There are some key signs and symptoms that are categorized by severity. The first one being compensated shock. The early signs and symptoms is going to be the body attempting to maintain perfusion by activating certain bodily processes. Tachycardia is the first symptom that's going to be present, and this is going to be a pulse based on the patient's size and age. It's going to be typically hanging over 100 beats per minute, and it's aimed at sustaining cardiac output. The next one is going to be tachypnea or fast breathing. With an increased respiratory rate, the body is trying to compensate for acidosis. And the last big one that we're going to be able to see as BLS providers is going to be a narrowing pulse pressure. The systolic for the patient will remain normal, and it will drop slightly as the diastolic rises. This patient is typically going to be hanging below 100 for their systolic and being presented with cool, pale, and clammy skin. This is because peripheral vasoconstriction directs the blood to the vital organs. Your distal pulses are probably going to be disappearing, and you're probably going to be noticing that the patient is turning pale at the extremities and maybe mottling at their core. If a patient is awake they're going to be presenting with anxiety, restlessness, and agitation. These are early indicators of hypoxia, and there's going to be delayed capillary refill when you're squeezing the patient's fingernail. This is particularly notable in children and younger adults, which would be the best ones to try and monitor for compensated shock. Children stay in compensated shock for a very long time compared to adults who kind of have a spread out reaction to their shock, but children will stay really good for very long and then they will go into decompensated and irreversible shock extremely quickly following their body finally letting its guard down. If the body continues to lose blood because you possibly have an internal bleed or a bleed that's not controlled, the patient can progress to decompensated shock. And while this is still a type of shock that patients can come back from, it's probably going to be with immediate access to some type of blood transfusion or replacement of the fluids that are being lost. So, some of the body's compensatory mechanisms will fail and worsening hypoperfusion will occur. One of the bigger ones that will be with late stage or decompensated shock is going to be hypotension. And this is where the systolic blood pressure is continuing to fall. And this is going to be definitely below 90. The tachycardia is going to increase to about 120 to 140 with very weak and thready pulses. At this point, the extremities can become cold or cyanotic because blood is at this time for sure being diverted away from the extremities. The patient can present with confusion, drowsiness, or even loss of consciousness. And one of the things that sticks out is I ran a patient back in October and he presented with decompensated shock very quickly after his original mechanism of injury. We ran a patient that was on a motorcycle. He was probably traveling about 60 miles per hour when he T-boned a car. The patient immediately was knocked unconscious, and bystanders tried to help. We got on scene very quickly, and the patient was confirming to have agonal breaths, but he had a carotid pulse still. When we cut the shirt, we saw that the patient had a very obvious sternal fracture, among other injuries, including open fractures and lacerations. Something that stuck out, though, is the fact that I actively watched procedures work well with this patient. And it wasn't entirely all bleeding control related, but on a side tangent, knowing your procedures and being able to perform skills while under pressure is only going to benefit the patient. So he was presenting with decompensated shock when we finally got him hooked up to the monitor. He had about an 80 over 60 for his blood pressure, and his pulse was hanging in the 120s. When we did a needle decompression for the pneumothorax that he had in his chest, we watched his body actually rebound really well on the monitor, and we got him to the hospital. Ultimately, the patient did not make it, but I don't think that he really could have gotten better care. We had an extremely competent team that was working on this patient in the back of the ambulance, and for that, I'm thankful. So it turns out that the patient had one of his major arteries that had been severed from the heart and realistically shouldn't have made it to the hospital. If you guys know your bleeding control and if you know about prioritizing your airway, breathing, and circulation, you're realistically going to do a lot for the patient. And sometimes they may even survive something that they weren't meant to even make it off the pavement. Now, bear with me because this might not be the most interesting information you guys have ever heard, but it is something that you're going to run into when you're going over patients' medication lists, and these are medications that you should keep an eye out for. So, the first one that we're going to touch on for blood thinning medication is aspirin. And while it's not necessarily a blood thinner, it's a antiplatelet medication that works by preventing the formation of these thrombose inducing chemicals that are located in the blood. This makes the platelets stick together and it prevents further blood flow through the vein. So this makes it different from other anticoagulants like warfarin, Eliquis, and Xarelto, which target the actual clotting cascade itself. Some indications for patients that would be put on aspirin are patients with acute coronary syndrome or a history of heart attack with unstable angina. You can also give these to patients that you believe are experiencing a myocardial infarction, and you can give them 324 milligrams of aspirin or 481 milligram doses. The patients that are put on aspirin also might possibly have a history of stroke or a TIA prevention for non cardio strokes, and they are the first line for patients with a history of ischemic strokes. This is not ideal for patients that have a history of atrial fibrillation related strokes, and there is a second device and medication that we'll be talking about in a few minutes that will touch on that. This is also given to patients for post stent placement, and they are often put on a combination of aspirin and Plavix. This prevents stent thrombosis. Lastly, it's for high risk medication patients for primary prevention, and it's no longer recommended for routine use in healthy individuals due to the bleeding risk, but it may still be used in patients that are over 40 with significant cardiovascular risk factors, including diabetes, hypertension, and those who smoke. Patients who should not take aspirin include patients with a history of active GI bleeding, ulcers, or recent hemorrhage, of course, an allergy to aspirin or an anaphylactic reaction to it, patients with a history of a hemorrhagic stroke as it can worsen bleeding, severe kidney or liver disease, and patients that have an upcoming surgery, which this medication is usually stopped 5 to 7 days prior to the procedure, unless it's a high risk cardiac patient. You should use caution if the patient has a history of GI ulcers, but ultimately, if a patient is experiencing a myocardial infarction, we're going to prioritize our patient's life because they can give them clotting factors when they get to the hospital. Patients that have concurrent use with other anticoagulants such as Coumadin, Eliquis, and Xarelto should not be taking an additional aspirin unless they are advised by their provider. And lastly, a patient that may be a contradicting factor is a patient with a significant cardiac history, but also a high fall risk, including the elderly, those who abuse alcohol, or experience frequent injuries. The second antiplatelet egregiate that we're going to be touching on is Plavix or clopidogrel, and this is an antiplatelet medication that's not a traditional anticoagulant like warfarin, Eliquis, or Xarelto. It prevents platelets from clumping together, reducing the risk of clot formation in the arteries. And unlike anticoagulants, which target clotting cascades, Plavix works by inhibiting them from aggregating. Some indications for patients that would be put on Plavix include those with a history of acute coronary syndrome like heart attack or unstable angina. This is used paired with aspirin to prevent further clot formation, and this can also be given in a hospital setting for a patient with a suspected STEMI. Patients that have a history of a TIA or stroke may be put on Plavix, and this is for non cardio strokes that are caused by arterial plaque and not AFib. This is often used instead of a blood thinner because the patient will not tolerate it as well. Lastly, patients with a history of peripheral artery disease. This reduces the risk of limb ischemia or lack of blood flow to the limb, heart attack, or stroke. Patients can also periodically be put on Plavix for a short time after a stent placement, and this is once again paired with aspirin for at least 3 to 12 months after the stent has been placed. Plavix should not be taken by patients with a active major bleeding GI or brain hemorrhage. The patient should not be taking Plavix if they have a planned surgery or dental procedure, as they should hold just like aspirin 5 to 7 days before the procedure, and they should not be taking Plavix if they have a severe liver disease or increased risk of bleeding. If the patient is waiting for a certain procedure and they need to be taken off Plavix, they can be put on a Watchman device, which is a left atrial appendage closure, and it's designed to reduce the risk of strokes with patients that have the conditions like AFib. AFib increases the risk of stroke because of where the blood can pool in the left atrium, and this leads to clot formation. These clots can travel to the brain, causing a stroke. The Watchman device helps seal off the left atrial appendage, preventing the clots from entering the bloodstream and reducing a stroke risk. Some indications for people who might be put and surgically implanted with a Watchman device is a patient with uncontrolled atrial fibrillation. These also may be patients that are non-compliant with taking medication on a regular basis or have increased issues like bleeding risks. The patient can also be using the Watchman device for stroke prevention, and this is for anybody that has an elevated risk for bleeding on blood thinners. They can use this as an alternative to chronic anticoagulation, and it offers a long-term alternative to those who cannot take it safely. The Watchman device is inserted via a catheter through the groin or femoral vein into the left atrium of the heart. Once in place, the device seals off the left atrial appendage, which is often the site where blood clots are commonly formed with AFib patients. This device is made of a self-expanding mesh that is designed to fit snugly in the appendage, preventing blood flow from entering it and trapping any clots. Over time, the tissue grows over the device, securing it in place and fully closing the left atrial appendage. Now, patients may not voluntarily give up this information as they don't seem to find it relevant, but if you have a patient that has some certain conditions that are listed, you may want to ask the patient if they've had any surgical procedures like an internal cardiodefibrillator or a Watchman device that has been implanted to regulate any pre-existing health risks. Moving on to the actual blood thinners now, the first one that we're going to be touching on is Eliquis or Apixaban, and this is a prescription blood thinner or anticoagulant used to reduce the risk of blood clots and stroke. It belongs to a class of medications called direct oral anticoagulants and works by selectively inhibiting certain factors. It's an essential component of the blood clotting process. Some of the uses for Eliquis can be prevention of stroke and blood clots with patients with AFib that are not caused by a direct heart valve issue. This can also treat and prevent DVTs and pulmonary embolisms, and some surgeons can elect to use this as a post-surgical clot prevention with surgeries such as hip or knee replacements, and it may be patients that don't tolerate taking an injectable medication like Lovenox or heparin. Those who should not be taking Eliquis are patients with a major active bleeding, such as a GI bleed or brain hemorrhage, those with severe liver disease or an impaired metabolism of the drug, people who have mechanical heart valves, such as a pig valve or a valve replacement, as warfarin is typically preferred, and patients that are high fall risk. The second anticoagulant that you're going to see quite frequently is Xarelto or Rivaroxaban, and this is a direct oral anticoagulant as well that prevents clot formation. It's similar to Eliquis but differs in its dosing and indications. Once again, we have atrial fibrillation, and AFib causes a stroke risk due to the clot formation. These patients will not have a history of a mechanical heart valve. Patients can be put on Xarelto for 90 days or longer when they have a history of deep vein thrombosis or pulmonary embolism. This prevents additional clots from growing and reduces the reoccurrence risk. If the patient has a history of DVT, it can be used chronically, and the patient can be put on a long-term dose of this. This can also be elected by a surgeon to be used after surgery, as the immobility causes an increased clot risk. These are, once again, hip and knee replacement surgeries, those big bones, and possibly even femur nails. A patient with coronary artery disease or peripheral artery disease is also going to be put on Xarelto. This helps reduce clot-related events like a heart attack or stroke, and they have a history of coronary artery disease, peripheral artery disease, or recent cardiac events that did not work with a typical low-dose aspirin. Some absolute contraindications that are seriously worth noting for Xarelto is a patient with severe liver disease. Anybody that has impaired liver function can affect the drug metabolism and actually increase their bleeding risk. A patient with severe kidney disease, Xarelto is not renally cleared and has severe renal impairment that increases drug accumulation and the ultimate bleeding risk of the patient. Patients that have mechanical heart valves are an absolute contraindication for taking Xarelto, as warfarin is preferred for anticoagulant use in these patients. Lastly, Xarelto crosses the placenta and is not recommended due to fetal harm, so anybody that's breastfeeding or pregnant is not recommended to take Xarelto. The last big anticoagulant that I wanted to touch on is Coumadin or warfarin. This is a vitamin K antagonist that prevents blood clot formation by inhibiting the production of certain clotting factors which depend on vitamin K. Unlike direct oral anticoagulants like Xarelto or Eliquis, warfarin requires frequent monitoring and can be adjusted based on patients' INR. It does have more dietary restrictions, and it is still preferred for the anticoagulant choice for certain patients. Patients that have a history of AFib or DVT, PEs are put on warfarin if they do not tolerate Eliquis or Xarelto. This is approved for patients that do have mechanical heart valves. Direct oral anticoagulants are not effective for mechanical valves, where Coumadin has that vitamin K antagonist that is specifically designed for mechanical heart valves. Patients that have thrombophilia or certain conditions like factor V Leiden or certain protein deficiencies are going to be put on Coumadin or warfarin, and patients that are post myocardial infarction in high risk patients are going to be put on this medication due to the high clot risk. Warfarin is highly individualized and its dose is based on the patient's INR, so they're regularly getting blood draws and getting this medication changed based on their actual values of their blood work. Patients that should not take Coumadin are patients that are pregnant, except in very high risk cases because it causes fetal warfarin syndrome. Patients who have uncontrolled hypertension have an increased risk of intracranial hemorrhage, and patients that have poor medication adherence due to its strict INR monitoring are not recommended to take this medication. Now, of course, there are other medications that thin the blood and treat blood clots that you should probably keep an eye out for, but these are the ones that you're going to see in common medication lists. And if the patient isn't necessarily familiar with why they're taking the medication, knowing some of the indications of why a patient could be taking certain prescriptions can help you out with guessing their medical history and narrowing down certain symptoms to try and get an idea of what the actual medical emergency is that the patient's experiencing.
My heart's crippled by the pain that I keep on closing. You cut me open and I keep bleeding.
Patients that take anticoagulants or antiplatelet egregiates do have an increased risk of having a harder time controlling their bleed. So, knowing some of their medication history can help you kind of take more advanced measures or figure out why the patient is not stopping their bleed. This can also give you a heightened increase for suspicion that the patient has increased brain hemorrhaging, such as an intracranial hemorrhage or a subdural hematoma that's developing. When it comes to internal bleeding or a head bleed, there's nothing that we can necessarily do to help the patient other than make sure that they keep breathing and keep their pulse. But something that you may not know is patients that are on anticoagulants or antiplatelet egregiates are often not sent to triage and they're put directly in a room to get advanced imaging and get evaluated by a provider sooner with blood labs that are immediately drawn. So, having this information ready for the ALS providers, or if you're transporting to the hospital, may save a patient's life, even if they're not presenting with life threatening symptoms. And that is the conclusion of this week's Stretcher Fetchers podcast episode. If you guys like what you're hearing, feel free to leave a comment. We are streaming on other websites as well, so feel free to share a link with a friend. Keep educated and keep doing awesome work out there. Have a great week.